Welcome. Today my topic of discussion is irritable bowel syndrome. Definition is a functional bowel disorder characterized by abdominal pain or discomfort with altered bowel habits in the absence of detectable structural abnormality. It's a functional disorder with heterogeneous etiology. Regarding prevalence, 2 out of 10. So 10 to 20% of the population sufferer. Come to the diagnosis. Diagnosis of IBS depends upon clinical presentation. Number 2, by exclusion of other intestinal structural abnormality of same clinical presentation by CT scan abdomen or ultrasonography abdomen, upper and lower GI endoscopy, stool tests, etc. What is the Rome floor criteria? So Rome floor criteria tells us recurrent abdominal pain for at least one per week for at least last 3 months with two or more of the following. One, pain related to defecation, pain related to stool consistency, and pain related to stool frequency. Next come to the pathogenesis slide. IBS genetic factor, increased serotonin transport in enteric nerve, psychologic factor, anxiety, panic attack, depression, somatization, altered gut flora with gut dysbiosis, decreased bifidobacterium species, lactobacillus, post-infectious causes, Campylobacter, Salmonella, Shigella, bile acid malabsorption. Next is the pathology. Hypersensitive intestine having altered intestinal mucosal permeability in IBS patients. As a result, there will be increased gut antigen presentation to mast cells. Mast cell activation. As a result, there will be increased intestinal pain sensation and increased intestinal muscular contraction. On the other side, as a result of mast cell activation, there will be release of systemic cytokines and chemokines. What happens? Extraintestinal symptoms occur as fibromyalgia, headache, backache, or chronic fatigue syndrome. You see here in IBS, there will be dysregulation of brain gut axis. In this picture, you see here this is the brain and gut. Gut means I want to say the stomach, small intestine, as well as large intestine. They are innervated by enteric nerve and vagus nerve. In the brain, I want to show few areas which are responsible for the pain perception. They show increased pain perception in IBS cases. What are these areas? These are prefrontal cortex, anterior cingulate cortex, insula, amygdala, and hippocampus. As a result of increased pain perception, there will be abnormal gut contraction. This is the dysregulation. What happens? Abnormal gut contraction occurs and the IBS patients are suffering from different abdominal issues. Now come to the triggers. The food allergy, particularly food present in the food map diet, stress, gut infection. Next come to the clinical features. It affects all ages but first symptom before 45 years. Male is to female 1 is to 3. Extraintestinal symptom as fibromyalgia, chronic headache or backache, chronic fatigue syndrome. No weight loss occurs. Regarding abdominal pain, it is episodic and crampy, mild to severe in intensity, exaggerated by eating or emotion, relieved after passing stool or flatus, premenstrual or menstrual worsening, pain only in wakeful state. Next is the altered bowel habit, may present with diarrhea, IBS-D type, or constipation, IBS-C type, or constipation alternating with diarrhea, that is IBS mixed type. IBS-D type stool volume is usually less than 200 milliliter related to the eating and emotion. Stool may contain mucus. Intestinal gas and flatulence, there is increased intestinal gas which causing abdominal distension, flatulence, belching. Upper gastrointestinal symptom occurs in 25 to 50% patient which shows heartburn, nausea, vomiting, dyspepsia, mimic acid peptic disorder. Now come to the treatment. Diet, low FODMAP diet, low or no caffeine and carbonated drinks. What is FODMAP? F-O-D, MAP. F for fermentable, O oligosaccharide, D disaccharide, M monosaccharide, A and P polyol. What high FODMAP diet causes? Excess FODMAP diet causing poorly absorbed carbohydrate in the small gut. As a result, carbohydrate antigen is being presented to the intestinal mast cells. Mast cell get activated. On the other side, this FODMAP diet with poorly absorbed carbohydrate act as an osmotically abstract substance in the intestine, causing water retention in the intestine. This carbohydrate also act as food source for the colonic commensals. As a result, there will be increased gas production in the intestine by the colonic commensals. So net effect is the abdominal pain, cramp, distension, bloating, flatulence and diarrhea. The summary of FODMAP activities. FODMAPs, which are short chain carbohydrate that small intestine does not absorb well. FODMAP can cause digestive issue. Why? Number 1. FODMAPs contain osmotically active substance which draw fluid into the small bowel which can lead to diarrhea. Number 2. FODMAPs get fermented quickly in the large intestine which produces gas that can distend the bowel and cause pain. Number 3. FODMAPs can lead to excess production of short chain fatty acid which can cause abdominal pain and bloating. What are the digestive issues? Cramping, diarrhea, constipation, stomach bloating, flatulence, abdominal pain, feeling full after eating or drinking a small amount. Normal people with normal tolerance can bear FODMAPs with minimum or no symptom. However, in IBS patients, they are particularly likely to experience digestive issues from FODMAP diets because of their sensitive intestine and sensitive brain. Next, come to the diet with high FODMAP. Third is the fruit, contains fructose, that is monosaccharide. Fructan contains oligosaccharide. Example: apple, mango, watermelon, pear, cherry, apricot. Nuts contains fructan. Example: pistachio. Vegetables contains fructan polyol. Example: cauliflower, green cabbage, onion, garlic, peas, beetroot, mushroom. Milk and milk product contains lactose, it is disaccharide. Example: milk, yogurt, custard, soft cheese, ice cream. Cereals contains fructan. Example: wheat, rye, barley. Others: honey, corn syrup, artificial sweetener, sorbitol. The most important statement is dietary approach with low FODMAP diet should be the first line of treatment for all IBS patients. Now come to the drugs for constipation. Psyllium has lactulose syrup, polyethylene glycol is helpful. Drugs for diarrhea, loperamide is useful in many cases. Next is the antispasmodic. Anticholinergic drugs or smooth muscle relaxants may be effective when used 30 minutes before for postprandial symptom. Antibiotics, non-absorbable oral antibiotic rifaximin is useful, 550 mg twice daily for 2 weeks. Next is the probiotic, Lactobacillus bifidobacterium species. Next come to the tricyclic antidepressant, useful in IBS D type, useful for pain relief, effective when psychological relation exists, Useful starting dose, maybe amitriptyline may be used for 25 to 50 milligram per day initially and then adjust accordingly. SSRI, when anxiety or depression is present. 5-HT3 receptor antagonist, allosetron, effective in IBS D type. Chloride channel activator, lubiprostol, effective in IBS C type. 5-HT4 agonist, tegaserod, may be effective in IBS C type in many cases. Common question: is lactose intolerance a subgroup of IBS? Answer is no. Lactose intolerance is not a subgroup of IBS. Its clinical feature is same like IBS, but it is due to deficiency of the gut lactase enzyme, which causes inability to break down milk lactose in the gut, causing lactose accumulation and symptom. Next question is gluten enteropathy a subgroup of IBS? No, it is not a subgroup. It is the same clinical features as IBS, but it is due to intestinal villus atrophy due to the effect of the gluten protein present in wheat, barley or rye. Now come to the important slide, take home message. Episodic pain abdomen with diarrhea or constipation at least once in a week for at least 3 months, suggestive of irritable bowel syndrome. Pain has emotional and eating relationship. IBS may present with epigastric pain with nausea and vomiting, very commonly misdiagnosed as acid peptic disorder. Rule out all structural disease of gut before diagnosis of a case of IBS. This is the most important statement. Low FODMAP diet. This should be the first approach of IBS treatment. Rifaximin antibiotic shows improvement in many IBS cases. Probiotic has role in IBS control, and antidepressant and behavioral therapy has definite role in IBS control if particularly patient having stress, anxiety or depression. Here doctor is thinking, how can I treat my IBS patient in outpatient department? Symptomatic treatment first of all for the pain, diarrhea and constipation. Next is restrict high FODMAP diet as present in bread, roti, meal and selected fruits. Next is the gut antibiotic as rifaximin or maybe metronidazole with probiotic for short course. And last not the least, tricyclic antidepressant or SSRI in anxiety prone patients. This is the slide which shows after treatment this brain and gut came in the same harmony. There is no dysregulation in brain gut axis. Thank you to all.